Hi, my name is Dr. Richard Elliott. I'm a professor and director of the Professionalism and Ethics program at Mercer University School of Medicine. This lecture is presented to third year medical students at the Mercer University School of Medicine during their clerkship in psychiatry. And it's actually one of several parts presented to students. This first part is on involuntary hospitalization. Additional lectures cover confidentiality and privilege, including the so-called Tarasov duty to protect, boundary violations, including inappropriate personal relationships, as well as capacity and informed consent in the psychiatric and medical patient. Our first topic is on involuntary hospitalization. This is something which most of you will experience whether or not you go into psychiatry, especially while you're working in emergency rooms. The following case is a fairly typical one that you might encounter as house staff or as a medical student. Consider a 65-year-old woman who's brought to the emergency room around 10 at night in January by police after being found walking the streets in her nightie singing hymns. Records indicate she has insulin-dependent diabetes mellitus. Physical examination is difficult to perform because she's refusing medical care, but she appears very thin and her right foot is dark in color. She insists on leaving so that she can bring, quote, the word of the Lord, unquote, to the people. What do you do? Think about this for a minute and then turn to the next slide. A number of options are available. One would be to offer her food and a warm, though not too hot, beverage. You don't want her throwing it at you if she becomes too irritated when she can't leave the emergency room. You could negotiate with her for an overnight stay, pointing out the lateness of the hour, the coldness outside, and perhaps she'll stay in the hospital at least overnight and let you form more of a relationship and evaluate her further. You can offer her clothing, both to protect her dignity, offer her warmth. You could try to find out where she lives, find out family members, others who might know her, and then with her permission, you can contact them to get more background information and see what means might be available to you to encourage her to go into treatment. And then you might consider involuntary hospitalization if nothing else works and you believe she presents a risk to herself or others were she to leave the hospital. I put this at the end of the list because too often we think too quickly about involuntary hospitalization when alternatives might exist that would preserve her liberty to a greater extent. In Georgia, the involuntary hospitalization process begins with a 1013 form, or in the case of substance abuse rather than mental illness, a 2013. We'll describe the difference more in just a minute. A 1013 includes the sections on this slide. I'd like to point out several of them. Near the top is the statement that this is to certify that I have personally examined the patient within the preceding 48 hours of the signing of this certificate. This is critically important. One should never complete a 1013 or any similar form in other jurisdictions without a personal examination. The examination does not need to be detailed. There are examples where a patient might be in a seclusion room and looking through the window where you see a naked patient throwing feces, cursing, and appearing to hallucinate would provide more than sufficient information to indicate that the patient is mentally ill. But to deprive someone of their liberty without at least a personal, no matter how cursory examination, would be at least illegal and probably unethical. Subsequent sections of the form we'll take up in more detail, but you'll see that The criteria are spelled out in the form that the patient represents a substantial risk of imminent harm to self or others and is mentally ill. At the bottom is another criterion which, in addition to mental illness, states that the patient has an imminently life-endangering crisis because he or she is unable to care for his or her own health or safety. Let's take a closer look at this. In Georgia, a mental illness for the purpose of involuntary hospitalization is not a DSM-5 or DSM-4 diagnosis. It's defined legally as a disorder of thought or mood which significantly impairs judgment, behavior, capacity to recognize reality, or ability to cope with the ordinary demands of life. This gives broad latitude to the physician or other person completing the 1013. And the basis for the finding of mental illness relies on personal observations, the recording of which might include with our patient that she's dressed inappropriately for the cold weather, that she's singing, that she is preoccupied with religious themes, that she's unable to assess her own physical health and the danger that going out into the cold would present. She's probably voluble, if not hyperverbal, and so forth. The point is that diagnosis of mental illness is not DSM related. It's based on personal observations, which indicate these various disorders in thought or mood, impairing judgment and behavior. In addition to being mentally ill, a person subject to involuntary hospitalization must demonstrate either substantial risk of imminent harm to self or others based on recent overt acts or threats, or be subject to a life-endangering threat because of his or her inability to care for health and safety. Substantial risk of imminent harm to self or others is usually apparent. A person has attempted suicide, for example, with an overdose, or has struck or physically threatened another person. The specific overt acts or threats must be documented, and they should have occurred fairly recently to when the evaluation is being conducted, typically within the previous 48 hours. We don't want to use behavior several months old to subject a person to involuntary hospitalization. The life-endangering threat in our patient would be because of probably severe diabetes with complications, which might include possible gangrene, and these should all be documented. Who may sign a 1013? Well, in Georgia, it's not just a physician, and certainly not just a psychiatrist, but others, including psychologists, clinical social workers, and clinical nurse specialists in the mental health field, may all sign a 1013. How long is a 1013 valid? Well, the purpose of a 1013 is to provide for an immediate evaluation, to determine whether a lengthier evaluation is necessary. It also gives a patient the opportunity to reconsider and potentially sign in as a voluntary patient. Thus, the brief period for an initial 1013 evaluation is only 48 hours. After the 48 hours has expired, the patient should either be discharged, would sign in as a voluntary patient, or a 1014 would be completed, which would give the evaluating team an additional 2 weeks to conduct a more thorough evaluation. This is usually done, the 1014 process, in another facility, for example, a state mental hospital, but the availability of beds is such that it's often difficult to transfer a patient for that evaluation, so sometimes the patient remains in the initial emergency receiving facility for a longer period of time because of the lack of availability of beds. As noted earlier, if the patient suffers primarily from a substance abuse disorder rather than a mental illness, but they present a danger to themselves or others, then a 2013 form can be completed, which is again good for 48 hours and can be changed to a 2014 if further evaluation is needed. Question often arises when patients threaten physicians who seem to have no alternative but to pursue a involuntary hospitalization through the 1013 and a patient threatens the physician, I've had this happen a number of times, I try to maintain a good relationship with patients and I try to explain to them what I need to do and why, and we need several days to complete the evaluation, and patients will still say, if you do this, doctor, I'll see that you never practice medicine again. I'll have your license. I'm going to sue you, and so forth, various threats. I've had this even after patients have unsuccessfully attempted to kill themselves with gunshot wounds to the head, where they miss, where they clearly had to use a toe to pull the trigger on a rifle, and nevertheless maintained that they were simply cleaning their weapon, or that the overdose with 100 of some sort of medication was an accidental overdose. Clearly that person needs further evaluation, and we shouldn't let these threats stop us. The law provides immunity for us if we pursue the 1013 process in good faith. And normally we do, there's no question. But should a physician make a statement such as, I'm going to show this so-and-so not to do this again, I'm going to teach her a lesson, we'll put her away where she can't be bothering us like this. Statements that are obviously malicious, influence judges, determiners of fact later on to conclude that this was not done in good faith and that the 1013 immunity does not apply to a physician who makes such statements. Now, the ethical foundations for involuntary hospitalizations are considered by some to be controversial, not by me. Clearly, very few people in society are given the authority to deprive a person of liberty, and this authority must be accompanied by great responsibility and great consideration before we resort to it. That's why we need to look at alternatives to involuntary hospitalization. But there are sound ethical reasons for pursuing involuntary hospitalization. The dilemma sometimes is seen because the ethical principle of autonomy would argue for giving great weight to the patient's decision not to be hospitalized and certainly not to be treated involuntarily. However, a risk-benefit consideration usually allows us to look at the principle of beneficence favorably and to give this even greater weight when we have the potential for saving a patient's life or saving the life of another. And so the principle of beneficence assumes predominance in such situations. One often hears also of state powers. The state has the power, or under the doctrine of parens patriae, acting as the father of the country, to look after the best interest of the patient. This is actually a principle from the Middle Ages, and it really had more to do with protecting the king's property, but still, the state does seem to have an obligation to protect patients who are unable to protect themselves. The state also has the power of, the authority under police powers to protect the safety of others in society, so that when a patient represents a threat to others, the state has the authority to involuntarily hospitalize and treat that patient to protect others. This is a very brief overview of the process of involuntary hospitalization, and if you have any questions, please feel free to contact me. Thank you.